As we all know that hypertrophic cardiomyopathy is a very heterogeneous group of disorders, especially in the childhood, because many of these patients have syndromic hypertrophic cardiomyopathy. They have a syndrome going on, like the rasopathies, the Noonan syndrome, the Leopard syndrome, and many other cutaneous manifestations. And then we have a large group which comprises of inborn errors of metabolism. And the third is, and when we have non-syndromic hypertrophic cardiomyopathy, so we have a heterogeneous group of patients which we are talking about, especially when we are talking about young onset or childhood onset hypertrophic cardiomyopathy. Okay, so why is this particular, ये screen off हो रहा है, okay. This particular subset is so important because we know that these young patient population, young patients of hypertrophic cardiomyopathy are even more susceptible to this particular event that is called sudden cardiac death. And there is lack of data on this particular subgroup, and lack of data leads to precision in risk stratifying these patients, further augmenting our difficulty that how to select the proper patient for ICD interventions. Adult models leads to risk stratification, which often gets underestimated, leading to lesser ICD implants. And we all know that younger patients are also more susceptible to complications of ICD therapy in the form of a lot of technical issues, the somatic growth later on leading to lead failures, other psychological and financial issues in children. And also, we know that the children have more inappropriate shocks. More than 11% do get inappropriate shocks in the long run. To begin with, just to apprise of the latest literature about the diagnosis and evaluation of patients with hypertrophic cardiomyopathy, we all know that the personal history, physical examination, family history are very important. And also, in the evaluation, 12-lead electrocardiogram, echocardiography, and the cardiac magnetic resonance imaging has really assumed an important role, not only in the tissue characterization, but also in risk stratifying these patients. And genetic testing, we know that lately has been added, and the American Association of Genetic Testing has recommended testing not only in the first degree relatives and the cascade testing to identify genotype positive patients who can be put under surveillance for later manifestations of the phenotype of hypertrophic cardiomyopathy. So we kind of characterize them. The genotype positive or phenotype positive, or people who are genotype positive or still phenotype negative, are kept under the surveillance. And as far as the clinical scenario is concerned, we know that heart failure and arrhythmias makes the management of heart failure and arrhythmia makes the cornerstone of treating hypertrophic HCM patients. Heart failure can be in the obstructive HCM or in the non-obstructive HCM. Depending on that, we have different management pathways. And arrhythmias, we know that the two major arrhythmias are atrial fibrillation and ventricular tachycardias. And even atrial fibrillation is not that easily tolerated in HCM patients and needs to be taken care of immaculately. And VT, which is the topic of today's presentation, we know that can be catastrophic in hypertrophic cardiomyopathy, often resulting in sudden cardiac death. So how do the childhood onset variant differs from the adult onset variant? As I discussed, the childhood onset variant is a more heterogeneous group. More patients comprises of other variants like inborn errors of metabolism. More patients have syndromic hypertrophic cardiomyopathy in comparison to the adults, where these two varieties lesser down in the proportion of patients. Childhood onset has more patients who have sarcomeric protein encoding gene mutation in comparison to the adults, where non-sarcomere encoding protein encoding mutations are more common. And we know that sudden cardiac death is more common in the childhood onset variant. Although earlier studies have reported up to the incidence of 8 to 9%, the recent literature says up to 2% per per year incidence of sudden cardiac death in the childhood onset variant. And we know that by the age of 40 to 50, all these patients who will have their manifestation of HCM in the childhood will have an event by the age of 50% will have an event by the age of 40 years of age. So very high chances of untoward events in the natural history of their natural course of their disease process. So higher ventricular tachycardia and also higher need for advanced heart failure therapy in the form of either assist devices, mechanical assist devices, or heart transplant in the childhood onset variant. So this is another study published in the JACC 2022, where the investigators further try to differentiate in the childhood onset variant whether the more younger population, that is less than 12 years of age, differs from the relatively older patient who are from 12 to 18 years of age, and they found out that again sudden cardiac death was even more common in the younger age group. So basically the study highlights the importance of the incidence of ventricular tachycardias, arrhythmias in the younger population, and the chances of sudden cardiac death. So this particular problem will make the cornerstone of treatment in the childhood onset hypertrophic cardiomyopathy. Again, highlighting that the sarcomeric HCM had very high chances of sudden cardiac death in comparison to the other two variants like IEM and rasopathies, where heart failure was a predominant mode of death. So now coming on to the risk, you know that this is a highly risk stratification is still long way to be covered. We have a lot of inaccuracies. The adult data is fraught with inconsistencies, and we still have lot of questions to be answered. So we have various guidelines released from time to time. As we know that many of the risk factors have been considered major risk factors which have established role in the prediction of sudden cardiac death. The 2003 ACC ESA guidelines enumerated 5 major cardiac risk factors, that is family history of sudden cardiac death, unexplained syncope, severe left ventricular hypertrophy, non-sustained ventricular tachycardia on ambulatory monitoring, and abnormal blood pressure response to exercise. And then there are potential SCD risk modifiers like LV outflow tract obstruction, late gadolinium enhancement on CMR imaging, genetic mutations, left ventricular apical aneurysm, and end-stage phase of hypertrophic cardiomyopathy. So what are the additional risk factors? There's increased left atrial diameter, young age at evaluation, and some of the risk factors which are still kind of under consideration, they do not have a definite role in risk prediction, are paced ventricular electrogram fractionation, QRS fragmentation on the ECG, exercise-induced arrhythmias, severe COPD, CAD, microvascular ischemia, mid-ventricular obstruction, and atrial fibrillation. So host of factors have been implicated along the way in various studies, and still, but we are far away from accurately predicting the future risk of SCD events. So what do the guidelines say? That the American Heart Association guidelines, basically when we go see the guidelines, they also differ among each other. The AHA guideline is more of individual risk marker strategy, although the ESC has lately in 2014 shifted from the individual risk marker strategy to the risk prediction model, right? They basically, this is the web-based tools where you add on the individual risk which the patient have, and depending upon that the tool estimates the total 5-year risk of sudden cardiac death. So the AHA basically says that out of these 7 risk factors, which are called major risk factors, presence of more than one major risk factor. So what are these major risk factors? Family history of hypertrophic cardiomyopathy or sudden death, unexplained recent syncope, multiple repetitive prolonged non-sustained VT. All these risk factors have been further defined also, and I think we should all go into the definitions of these risk factors, because there are a lot of gray areas when we apply these in clinical practice. Left ventricular aneurysm, massive left ventricular hypertrophy that is more than 30 mm, extensive late gadolinium. What is extensive? More than 15% of the left ventricular endocardium. end-stage disease, that is ejection fraction less than 50%, and age. So these are the major risk factors. Any presence of more than one risk factors that the AHA says that these patients should be considered as high risk and all should be offered ICD as a primary prevention strategy. Those people who doesn't have these risk factors, they fall in the category of low risk and they probably perhaps do not need ICD. And in between becomes a gray area where you need further decision making based on patient perspective and physician judgment, and then possibly some of them who fall under the category of higher, that is 3 to 4% per year risk of future events, they will appropriately need an ICD. Others can be kept under close surveillance. So now what do the guidelines say for the childhood onset variant? Again, as I said, guidelines do not specifically say anything on the childhood onset variant except that they have tried to dichotomize in the patients who fall under the gray area. Those patients who do not fall under the definitive high risk category, those patients are further subjected to ambulatory monitoring, and those who have non-sustained VT on Holter, if the patient is less than 16 years of age, they become a 2A indication for ICD. But this particular parameter does not hold for the adult patients. Though they still be categorized as the 2B, that may be an ICD is beneficial. So AHA guidelines have just tried to dichotomize this in the gray zone area where they have tried to differentiate them on the basis of non-sustained VT findings on Holter. Right? So as I said that the two guidelines have different strategies. One is individual risk marker based, another is a risk prediction model. The risk marker strategy estimates relative risk, not absolute risk. So this is what the ESC guideline says, that basically the risk prediction model may be a more, give you a more idea of an absolute risk rather than a relative risk, and it definitely takes the different effect size of individual risk factors into account. So some factors in the AHA guidelines are counted as binary variables, whereas they have a continuous risk effect. For example, the left ventricular wall thickness, left atrial diameter. So these risk factors, they have a continuous effect size, so they should not be taken as a binary risk as either yes or no. So ESC came with this risk model which is called as HCM risk SCD score based on these variables, which is age, family history of sudden death, unexplained syncope, LVOT gradient, maximal LV wall thickness, LA diameter and NSVT, and then differentiate the patient into three tertiles, there's high risk, intermediate risk and low risk. Now, what does these recommendations do they hold for the childhood variant? The HCM risk SCD, especially pediatric patients, were excluded. Competitive sports, elite, patients into elite sports were excluded. Patients with metabolic disease, after myomet. So these patients were not included into the trials. So they do not hold for the pediatric population. So where do we stand? So the 5-year risk of sudden cardiac death is very high in the young population. Clinical and genetic predictors vary from the adult onset disease, and the large cohorts has revealed that only 25% patients received ICD, where event was eventually averted. So that means a lot of patients are still being untreated. And also, many patients actually died or received ICD after an event, that is, they received as a secondary prevention. And 86% didn't receive an appropriate shock even at 5-year follow-up. So we have got a double-edged sword here. Although we are not only under-treating these patients, but those who are being treated, many of them are receiving inappropriate therapy. So ESC has developed and validated web-based tools, that is the HCM risk, and this risk model do not apply to children. So what do we do now? Where do we go now? So there are a lot of risk models being presented which are specific to the younger population. One of them is HCM risk kids model. One is primary risk prediction model. And then there are a lot of combination of these risk prediction models, that is, with the ECG risk score combined with the HCM risk kit score, the CMR score combined with the HCM risk score. So there have lots of things have been postulated, but many of them still needs to be validated in large randomized trials. So DELT model has limited discriminatory power, better discriminatory power between expected and the observed risk. Family history of sudden cardiac death and age are not included when we calculate the risk prediction for the younger population. And they said the LVOT gradient has actually got an inverse relation to sudden cardiac death. So there is basically more than 100 millimeter mercury of gradient means basically the patient has got lesser risk of sudden cardiac death. So this was found in the large observational trial. And this HCM risk kids model also, when they tested the accuracy of this particular model, they found that this particular finding holds true for the younger population. And unexplained syncope, degree of hypertrophy, LA diameter, and non-sustained VT, all these are strongly correlated with the risk of sudden cardiac death. So similarly with the primacy risk prediction model, and I said these are the different definitions taken for the different risk factors. So to summarize, childhood onset hypertrophic cardiomyopathy has a positive association with SAD. No association is found with LVOT gradient and family history. There's inverse association with the more than 100 millimeter mercury of gradient, and non-linear association is, positive association is found with syncope, degree of septal thickness, non-sustained VT, and left atrial diameter. So to summarize, we know that childhood onset variant has clinical and genetic features that are distinct from the adult onset variant. Extrapolation of data from the adult onset registries and observation studies is fraught with inaccuracies and errors. Pediatric specific risk prediction models are being developed and are still to be validated in large randomized trials. And precision in SAD risk prediction is cornerstone for shared decision making and preventing catastrophic SAD events. Thank you very much.